It's that time of year again, open enrollment, and we're here to help you make the best decision possible for Medicare 2026. Take a look.
Welcome to In Good Company, Elder Care in Your Backyard.
Most of you have heard by now that Medicare 2026 is going to be the year of changes. In fact, many have said that Medicare 2026 is Medicare resetting itself. So the question is, do you know what's changing for 2026 and why? But most importantly, do you know how you're going to respond to those changes? Those are the topics I'll be covering in this video so that when the changes come, you respond properly and something good can come out of it. Change is going to be affecting all parts of Medicare in one way or another. In this video, we're going to talk about Medicare A and B, supplemental plans, drug plans, and Advantage plans so you're aware of all the changes. If you're no longer working, your spouse is no longer working, and you are on Medicare A and B, what's changing for next year? Let's first talk about Part A. Part A is the inpatient side of Medicare. It covers hospitalization, skilled nursing, and hospice care. Right now, the majority of you are paying zero for Medicare Part A because as long as we paid into the Medicare tax system for at least 40 quarters, 10 years of working, or our spouse did, we don't pay any premium for Part A because we paid for it during our working years. About 1% of the population actually pays for Part A. Right now, if someone has 0 to 29 quarters, they're paying $518 a month for Medicare Part A. If they have 30 to 39 quarters, they're paying $285 a month for Part A. Some people have to buy it. I would suspect those amounts are probably going up a little bit next year. Medicare has not given us all the numbers yet. I'm recording this video on October the 13th, and they have not announced them yet. We're anticipating them sometime this month or maybe even to November. Let's talk about Medicare Part B. The majority of Americans are paying $185 a month for Medicare Part B. Again, we don't have the numbers yet for 2026. Most are anticipating an increase somewhere around $20 to $22 a month. That's about 10 to 11%. If you're on Social Security, Part B comes out of your check. If not, you're billed quarterly or have some kind of bank draft setup. The Part B premium is based upon income. Part A was based upon quarters. Part B is based upon income. Medicare establishes thresholds and looks back 2 years at modified adjusted gross income. For 2025, they look at 2023. For 2026, they'll look at 2024. Modified adjusted gross income is line 11 on your tax returns, plus line 2A. That number determines how much you pay for Part B. If you're a single filer and your modified adjusted gross income is $106,000 or less, this year you're paying up to $185. If you're married, filed jointly, that number is doubled to $212,000 or less, and you're paying up to $185. About 85% of the population is in this bracket. However, some of you are considered to be high income and have additional charges beyond $185. We call these IRMAAs, IRMAAs, Income-Related Monthly Adjustment Amounts. As they look back 2 years, if you're above the thresholds, you'll have an IRMAA surcharge. We anticipate the thresholds for 2026 will go up a little, likely around $109,000 to $110,000, doubled if married filing jointly. There are 5 levels of IRMAA. The lowest is about $87 and change, and the highest level is around $527 and change per month. They'll add IRMAA to the base. IRMAA also applies to Part D, so if you have an IRMAA on B, you'll have one on D. That brings us to supplemental plans, also called Medigap policies. When people are enrolled in a supplemental plan, they've chosen to stay in original Medicare A and B. That pays first. Because Medicare doesn't pay 100% for anything other than a preventative service, people buy a Medigap policy to fill in those financial gaps, either fully or almost in full. The Medicare Annual Enrollment Period, AEP, runs October 15th through December the 7th, but it has nothing to do with supplemental plans. We have AEP because of Advantage plans and drug plans, which are annual plans. Medigap plans are written for life. The only thing that can change is the premium, and those increases occur at different times depending upon the carrier and your policy and birthday. You can change Medigap plans any time of year, though you normally have to go through underwriting. Because millions will be making changes during AEP, underwriters get backlogged, so you have to plan to switch. Sooner is better. Many of you are already on the best plan at the best price, but if you do switch, consider doing it relatively soon. We've seen more rate increases in the last 2 years than in many prior years. Medicare inflation has been high, and people who delayed care during the COVID years returned to get surgeries and procedures, increasing those claims. Another trend is people waiting until they go on Medicare at 63 to 65 to get major surgeries, rather than using an employer plan with a high deductible. We think this will stabilize, but it has caused pain for Medigap plan premiums recently. Historically, increases might have been 5% to 7%. Lately, more like 10 to 20%. We're optimistic that this will settle as inflation gets under control and the delayed care surge passes. As for options, some of you are still on Plan F. If you started Medicare before January 1st, 2020, F is an option and you may be on it, but prices have edged up over the years. You could move down to a Plan G or Plan N. Plan F covers all 6 Medicare gaps. Plan G covers 5 of the 6. The gap it doesn't cover is the Part B deductible. This year, $257. Next year will likely be a little higher. Plan N covers 4 of the 6 gaps. It does not cover the Plan B deductible or excess charges. Excess charges are rare. Most doctors accept assignment and cannot bill excess. In 8 states, completely prohibit it. But if it happens, Plan N members would pay that excess. Plan N also has a $20 office visit copay and a $50 ER copay. Moving from F to G can often save you $50 to $100 plus per month. Moving from G to N can save about $40 to $50 per month on average, or roughly $500 to $600 per year, sometimes more. Whether that trade-off is worth it depends on your tolerance for small, occasional costs versus premium savings. On underwriting, in most states to switch Medigap plans, you go through underwriting, about 35 to 40 health questions, a medication review, and sometimes, rarely, a doctor statement. Carriers differ. Some care about BMI, some about certain medications, insulin usage, or specific conditions. As brokers, we match you to carriers most likely to approve you. If you're declined, there's no harm done. A few states, New York, Connecticut, Massachusetts, don't require an underwriting. About a dozen birthday rule states allow a same-level switch around your birthday window without underwriting. If you're healthy, you can move anytime. If not, the birthday window may be your path. Some will switch from Medigap to Advantage plan this year because of premium pressure. There's no underwriting for Advantage plans. If the plan is your zip code, you can enroll. To switch for January the 1st, you must apply between October the 15th and December 7th. Your Medigap stays active through December 31st. The Advantage plan then starts on January 1st. Now, standalone Part D drug plans. If you're on a supplemental plan, you also have a separate Part D plan for self-administered medications, pharmacy, or mail order. The most important thing is your annual notice of change, your ANOC. You should have received it by October the 1st. If you didn't, call the number on your card and request it. The ANOC discloses everything changing for 2026: premium, deductible, formulary, and tiers. Plans were allowed to raise premiums by up to $50. Roughly 20% took the maximum. Some went up slightly, some even went down. The 2026 standard deductible is $615. That's up from $590. Some meds are deductible exempt and have a low copay right now. Tier 3 through 5 meds typically apply to the deductible, so you pay full cost until you reach it. The maximum out-of-pocket on covered drugs is $2,100 in 2026. That's up 5% from $2,000. Once you hit $2,100 out-of-pocket on covered formulary drugs, you're done for the year. If you enroll in an MAPD Advantage plan with drug coverage, the drug benefit is embedded. There are also MA-only options for people with VA, TRICARE for Life, or FEHB coverage, because those members get drug coverage elsewhere that is creditable. MA-only plans often include a Part B giveback that reduces your Plan B premium or increases your Social Security check. Amounts vary by market and plan. For those on Advantage plans, there will be significant changes this year. About 2 million people are seeing plan terminations. Carriers are exiting unprofitable markets or consolidating. Some plans are being crosswalked to similar but not identical plans. Read your ANOC carefully. Compare out-of-pocket costs, hospital, specialist, primary care, imaging, outpatient surgery, provider networks, and prescription coverage. Perks like dental, vision, hearing, OTC cards, and gym memberships are generally tightening versus 2024 through 2025, with some plans limiting dental to preventive only or changing allowances. We're seeing a market shift from PPOs to HMOs, or HMO POS, HMO with limited out-of-network point of service options, because PPOs have been less profitable for carriers. Also, note chronic conditions, SNPs, special need plans, for conditions like diabetes, cardiac, or pulmonary issues with tailored benefits, copays, and networks to those needs. Key dates: AEP is October 15th through December the 7th. Changes made then take effect on January the 1st. OEP is January 1st through March 31st, but you must be on an Advantage plan on January 1st to use it, and you can make one change during OEP. Switching Advantage to Advantage involves no underwriting. Switching Advantage to Medigap generally requires underwriting in most states, except New York, Connecticut, and Massachusetts. So start early if that's your goal. Finally, where to get help varies widely in quality. Cold calls are risky and often come from unknown or even overseas operations. TV 800 numbers frequently connect you to third-party marketing organizations that sell your information as leads to multiple entities, which can trigger a flood of phone calls. Large call centers can be hit or miss, with high turnover and pressure to push certain plans. Captive agents are trained and can be very good, but they represent a single company and therefore have limited options to offer you. Independent brokers act in your interest by comparing multiple carriers for rates, benefits, and rate stability. They can also help with Medicare enrollment, IRMAA appeals, and switching among Medigap, Advantage, and drug plans, guiding you to the best fit for your situation. We will put a few options here in the show notes. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company Elder Care in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.